Hey everybody, long time no see. My name is Rachel. I'm one of the PAs here at Jemsek Specialty Clinic. I got to talk to you guys a couple months ago with Dr. Jemsek, and I joined him again today. We're going to be going over questions that you've sent in, similar format to before, but a little change. We're going to be going over some roadblocks that Dr. Jemsek and I wanted to discuss with you. But let me have Dr. Jemsek say hello and give you some updates before we do that.
Hey, good afternoon and welcome. I just wanted to reiterate how proud we are to be able to converse with you and to answer your questions, and to emphasize that above all, we want to keep this as professional and informative as possible. That's our goal. We're not going to go political, although this is a politically charged illness, so we'll never do that. We want to be informative and honest and helpful, and God knows we all need help at some time or other. I'm going to give you an interesting paradox about our illness. As you know, we have several providers here. We've been doing this for 20 years. And the paradox is that the more we learn from the patients and from our own curiosity, and the more we catalog, the harder or more difficult our cases become, because we have to follow those webs further than we ever have before, which is to your benefit. But those complex cases become even more complex, and it's a challenge, but it's also fascinating, and that leads to the subject of one day what we do becoming its own discipline, which I fervently believe should happen. It's obviously a complex multifactorial illness which requires many, many different skills, and it needs its own discipline. So let's all pray that that happens someday. Finally, a bit of sad news. Because of COVID, and we've all been impacted by COVID dramatically, GLA study has been interrupted. As you know, it was the first ever scientific collaboration, patient-sponsored through GLA, participation with a private clinic using our protocol. And we were doing really well and recruiting really well, but it just became too difficult with travel and support services in terms of venipuncture and all kinds of other issues. So unfortunately, it's on hold to be resumed. In the meantime, I do have a couple other projects ongoing which we can talk about at another time. And I'm going to turn it back to Rachel so she can introduce the 4 topics today.
So with the clinic, as we have been treating and diagnosing many, many patients, we have identified multiple roadblocks that patients encounter. Dr. Jemsek has been able to identify 25 plus roadblocks that have influenced or impacted patients' ability to treat. We wanted to cover 4 of those today in a little bit more detail, and we'll go over more of them, of the 25, in future live stream episodes. Sure. The 4 we want to go over today are poems instability, peri or premenstrual volatility, Babesia reoccurrence, and subacute acalculous cholecystitis. And we're going to start with poems instability, and I'll have Dr. Jemsek cover that one.
Okay, this format won't take very long. We'll try to cover about 15 minutes, then get to questions. But I did think it was important. Now, this is not posted on our website as of yet. Perhaps it will be one day, but I didn't want to overwhelm everyone and have all kinds of questions coming in that we couldn't answer all at once. But we do literally have 25, and it's a growing list of conditions that preempt or contravene against care, initiating care, or even during care, the complications that make us terminate care for the time being. So on our website, we do have prominently displayed, however, poems, P-O-E-M-S, which is our mantra, and where P stands for pain. And we could do a whole hour on the types of pain, but as you know, there are multiple types of pain requiring multiple different approaches. And pain has to be resolved, or to a satisfactory degree, to move on. O is for other, which means primarily support personnel, but also all these 24 other conditions that we're going to discuss. We're going to discuss 3 of them today. E stands for endocrine, where since the hypothalamic pituitary axis is so heavily damaged, we see all kinds of endocrinologic issues, and must identify those. M stands for mood. So all of our patients are irritable. That's kind of the ground floor. Everybody's irritable. And when I say that to somebody, the spouse generally winks and smiles, and then it just goes from there. It can go all the way to, paranoid, schizoid type activity, hallucinations, etc. And we need to have our patients on the playing field as we're going through therapy. So either through our treatment or with the help of psychiatrists, we're able to do that in most cases. And last is sleep, the absolutely fundamental and necessary element that we all need. We all have to sleep, and that's another subject for another hour, another 40-minute session, if you will. Bottom line is sleep, deep sleep in particular, different stages of sleep. Deep sleep rinses our brain. If we don't rinse our brain at night, toxins carry over into the next day. So that's our poems, and you can look on our website and see it there. Rachel's going to talk about premenstrual volatility.
Yeah, so the premenstrual volatility is something that we saw a trend of being an issue with multiple patients. What we think happens with this, or what we know happens with this based on the science, is essentially before your menstrual cycle, we are seeing an inflammatory cascade occur. When that happens, typically it is causing increase in all of patients' baseline symptoms, females, of course, that have a menstrual cycle. If this is just a day or two before the period, it's not as disruptive, but many of our patients have, that volatility 4 to 5 to 6 days before their period, which means that they are being, irritated with increased inflammatory symptoms for a good chunk of the month, which impacts their response to antibiotic therapy. How we approach this is with, ovulation suppression or birth control, which can help to mitigate the hormones that affect that inflammatory cascade. Many women can't tolerate, birth control, hormone-based birth control, and we do work with GYN or gynecologists that place these patients on birth control, as this is not our expertise. But if they are unable to tolerate birth control, we use omega-3 to help suppress or block the prostaglandin activity as much as possible. The next subject that we wanted to discuss or touch on is Babesia reoccurrence, and I'm going to pass this back over to Dr. Jemsek.
Thank you, Rachel. Just to add real quickly on that, the whole point of having volatility for 5 to 7 days, that's 7 days out of 28, 5 days out of 28, that's too many. There's such turbulence there that we can't get immunologic recovery, and in fact our treatment is all about immunologic recovery, because the better that you do with our pulsed intermittent therapies, the less we do, and that's our goal over a period of months of treatment. And the other point is that I learned a long time ago it wasn't the smartest thing to get into female hormones. So I try to stay away from that, and everybody seems to understand, thank goodness. So we're going to talk about babesiosis, and those of you who may have heard a lecture or two of mine, I'm kind of out there, I think, but not really, as far as thinking that babesiosis is the driver. So Babesia is a pyroplasma in the malaria family, of course, thought of for a long time to be a zoonotic or just a veterinary disease. There are 2 species that we recognize. There are probably more. There are definitely more out there, many, many species. The 2 major human pathogens are Microtia and divergens, or Duncani is another name. And we feel like, with the exception of a small subcategories of patients with advanced borreliosis, that Babesia is a player, and a major player. It blocks the immune response. It sort of frees the spirochete, if you will. And we know there are a host of other pathogens involved. So it's a consortium of pathogens, and teleologically, or going back in terms of why did this evolve, I don't understand how this evolved, but it did. And so we have a set of organisms headed by the spirochete as the tip of the spear, but Babesia is the driver. because I feel that the spirochete is something that's in many of us already, because once it's in, and it can get in very easily at any stage of life. Whether it's vertical, mother to child, whether it's sexual, whether it's an incidental tick bite or arachnid bite or horsefly or who knows, mosquitoes maybe even, just takes one. Babesia is tough to treat. It requires several months of pulse therapy with combinations. We use an equal amount of herbals and anti-infectives or antiparasitics. And the majority of our patients come in with a swollen liver, swollen spleen as a result of the congestion that occurs because of constant streaming of the infection, which is Babesia. And I want to give you an anecdotal story because this is the practice of medicine. And it convinced me that Babesia lives in the biofilm. And that's, so I think if there's any shortcoming by some of the Lyme providers that see constant recurrences and failures, it would be that biofilm is not handled correctly, Babesia is not handled correctly. Here's the story, and this was about 8 or 9, 10 years ago. After a few years of looking around and trying to figure out what to do with biofilm, I was afraid to take anything too strong and wasn't really thrilled with what was out there because I didn't want to blow up my patients and release all kinds of things in biofilm. Early precept: when you treat biofilm, whether it's intentionally or by accident, you have to kill what comes out. Okay, you have to kill. If you're going to break up the biofilm and release the dormant embedded organisms and break up their happy home, they come out. They're called planktonic, which is free living, and they're going and what are they going to do? They're going to affect other cells, kill other cells, and make more biofilm. Then you have chaos, and you have a progressive deterioration. So, like 9 or 10 years ago, I read some articles. I talked to some people in the West, in Montana, a surgical group that did sophisticated work with complicated wounds, and they were using xylitol and lactoferrin. Their PhDs had come up with this. Now, xylitol and lactoferrin have been around a long time. It's been in toothpaste for years. And Procter & Gamble figured this out a long time ago to get rid of the biofilm in our teeth. So it's been around for a while. Anyway, the PhDs started using it, and they started using it in surgical practice for complex wound, and because they wondered if biofilm was playing a role in their complex surgical wounds or diabetic-related wounds, etc. But they did a lot of good work and important work in establishing parameters about what doses to use. So I talked to the people and I said, well, okay, I'll give it a try. I was pretty skeptical. So I took, over a period of weeks, I took a group of patients who were stable, who may be on maintenance 1 week a month, and I said, okay, I've got something I want you to try, but we're going to try it for a week. Don't take other sweeteners, please. Let's just do this and let's see what happens. So, as I said, these were patients coming in over a few weeks. And because they were stable, they only came back every 3 to 6 months. And they started coming back. And as they came back, I got the same story over and over again, because when I would ask, well, how you doing? Because everything was just fine last time. We tried this xylitol. How'd it do? He said, what the hell did you do to me? Oh my God, I had to go to bed. I had fever again. I got sick. I have no energy. I can't hardly walk anymore. My joints are swollen. I got headache again. I was fine until you introduced that stuff. And I thought, okay, that's 1. And then it was 2. And then it was like 25 out of 30. And because we're very careful about doing repetitive exams, and we think that's important to put our hands on our patients and skillfully examine them, as many of our patients know, we examine you, right? We touch you, and we listen to you. So an abdominal exam, if you know how to do it carefully, only takes 20 seconds, 30 seconds. Well, what I noticed when they left before starting xylitol, which is a sugar alcohol like stevia, was that none of them had an enlarged spleen or liver. When they came back, they all had puffy livers and puffy spleens. Lesson learned. Well, I sort of got the message after the fourth one came in, but by then the gate was open, and I had another 26 to follow. So obviously I didn't use any xylitol until we got a handle on this. The point is that Babesia is in biofilm, and if you don't address in a synchronous way treatment of Babesia with a group of agents, and you need a group of agents, you will not be successful. You're going to have recurrence and relapse, 100%. And this is very important. Now, in treating Babesia, we try to target it early, but you know what? At that time, the immune system is not very strong. And clearly we need T-cell response or cell-mediated response in our immune system to treat this intracellular infection, which parasitizes red cells, but also gets into biofilm and all over the body. We don't feel that Babesia itself is that destructive or pathogenic, but it is an enabler. It's a major enabler, and absolutely necessary for Lyme borreliosis complex to clinically manifest. So we have recently, because as we follow our patients, we've recently decided to make a change in the way we treat people regarding babesiosis, because it's our #1 reason for people relapsing. And that's why we have babesiosis on the pothole or the roadblock list here. It's #1, really. And we need our immune systems. We don't have it early on because patients are immunocompromised for the most part. And we've discussed it with our patients. Everybody's on board with it. Once you get to maintenance after 12 months of therapy and you're doing great, you got blue sky days and weeks, and starting to really recover, and the immune system's on the recovery and you're healing, we said, okay, we're going to do that for a while, and we want to retreat you for Babesia with the immune system on board. So that's another shift in JSC's approach, clinical approach. And that way we hope we can reduce recurrences by 50 to 75%. Anyway, it's the boogeyman. Trust me.
Thank you. And then the last of the 4 points that we wanted to cover about roadblocks with this live stream was discussing subacute acalculous cholecystitis. And I'll pass this back over to Dr. Jemsek.
Acalculous, it's a subacute or chronic acalculous. Acalculous means no stones. As most of you know, gallbladder disease, and typically classically in previous century, was associated with stones. Female and 40 was the mantra and the acronym anyway. That dates me, I guess. We don't use the word blank AT anymore in the clinic at all. I get stuff thrown at me. Mm-hmm. Been hit a couple times. Almost seriously damaged. At any rate, for years and years we've noticed that, again, with our examinations, and you have to examine, and people tease me because I'm pretty firm. I don't want to hurt people, but I find stuff. And Rachel and others are doing the same thing. So when we examine you, it's not like it was just pat you on the tummy and pat you on the chest and pat, we do firm, non-aggressive examinations, looking for trigger points and looking for physical findings, whether it be in the bony skeleton or whether it be in the viscera, whether it be in the head and neck area with neurologically paraspinous area, and so forth and so on. Anyway, in the process of examining patients, we noted we had a lot of right upper quadrant tenderness, and particularly a pattern of seeing it in patients with pernicious nausea, bloating, reflux that they didn't really have before. Anorexia, meaning no appetite and so forth. Anyway, over the years, we have done imaging, and because we have to jump through hoops, we do an ultrasound, which is a sound wave test, sonar test of the gallbladder area. Those are going to be negative because the gallbladder usually is not thickened and there's no stones. But we go on with a HIDA scan, which is a study which provides a hormone which stimulates the gallbladder, a natural hormone from the pancreas when it sees a fat male coming down the pike. And there's a dye given that the radiologist can measure to see how much is ejected. The key thing is, when this test is done, does it hurt the patient? Does the patient suffer? Because nothing should happen, quite honestly, if you're just emptying the gallbladder. And so we've determined that the criteria for diagnosing the disease are entirely different. Been working with the Reston Surgical Group in Reston, Virginia, which is 30 miles from here. The last 4 or 5 years working with a wonderful surgeon. He's a clinical professor of surgery at the Reston Medical Center. Dr. Kareem Trad, T-R-A-D, just wonderful. Dr. Trad and I have collaborated and written an abstract on 86 of our patients, 68 of which were valuable. And it's going to be presented at a surgical meeting internationally, hopefully. COVID has, complicated everything. The point is you need to get the gallbladder out. So typically, here's a typical story. A teenager, teenagers having gallbladder disease in the past, really. A teenager will go and Jemsek will say, we think he's got inflammatory gallbladder disease. And the surgeon will say, nah. And I'll say, did the surgeon examine you? Not really. And he said, your HIDA scan was normal ejection. Yeah, but it hurt like hell, doc. Well, it doesn't matter. You're young and your gallbladder is fine. And we hear that all the time. And we now have a letter that we send to out-of-state surgeons so that they can understand this is a disease that's been around for 30 or 40 years, quite honestly. At any rate, Dr. Trad comes to the rescue. We have patients coming from Ohio, from Pennsylvania, from the Carolinas, Georgia, to have their gallbladders removed here in Northern Virginia because they can't get cooperation at home. Because guess what? This disease entity, subacute acalculous cholecystitis, is not in the surgical textbooks. You can't find it. It's a new disease. So Dr. Trad is bubbling with excitement about this. I mean, how often do you get to, insert a new disease in the textbooks? And this is a new disease, but in fact, I'm sure we've sent 600 to 800 patients for cholecystectomy. And typically, when the surgeon gets in there, even especially the skeptical surgeon, they say, "Oh my God, your gallbladder was blue, purple, had all sorts of fibrous tissue around it, was matted against the wall. It was just ugly and nasty." And they'll say, "I can't believe how bad it looked." And we hear this over and over and over. If we remove the gallbladder as a laparoscopic procedure on an outpatient basis, the patient feels immensely better 90% of the time. Immensely better because you removed an inflammatory stream coming from this visceral organ. And once it's removed, you can lower the quotient. So Dr. Trad and I are very excited to go forward with the abstract, which is all done, ready to present, and then followed up with an article, which would be a seminal article. And that's quite an honor for Dr. Trad and me and for our patients. And our patients get it, and we're just seeing more and more of it. Now, by the way, the basis for this is a chronic inflammatory state, 24/7. That's what's going on here, because we've seen gallbladder disease in HIV patients who also had the same situation. Not many, but it's reported. And what happens is that the liver can't neutralize the reactive oxygen species that are coming through, so the bile comes out hot, if you will, comes out oxidized, comes out toxic. So that bile is then concentrated in the gallbladder week after week, month after month, year after year. The gallbladder gets excoriated, it also gets infected. And between those two elements, the gallbladder starts to break down and scar down and become an inflammatory mess. So those are the first 4 of our 24 or more roadblocks. And I hope you've enjoyed it, and we'll go on with questions. Thank you.
Just to clarify why we throw things at him, in medicine we're still taught a mnemonic that's kind of a key for understanding patients that may have gallbladder disease, and it's females fat, which is what we throw things at him about, fertile, and
40.
And 40. So because I'm a female, I can say that. And it does tend to line up. But that's for more classic gallbladder disease. Obviously, Dr. Jemsek has just done an excellent job of explaining how the gallbladder is involved as it pertains specifically to Lyme. So getting into some of your questions, the first one that we wanted to cover, there were 3 questions that conveniently kind of clumped together. So I'm going to read those and then have Dr. Jemsek respond. The one was, why are Lyme patients so sensitive to overstimulation, especially when there are multiple sources dividing our attention? For example, I struggle to read or have a conversation if there's music playing or someone else is talking. The other question including this was, why do Lyme patients panic and shut down in noisy or busy environments? And third, why does stress significantly exacerbate symptoms? If I get upset or annoyed, I feel extra wiped out the rest of the day. Dr. Jemsek?
Thanks for the easy ones.
You're welcome.
So there's several modalities here. As far as we'll start with the last one. I think the stress. There's something I call the devil gland at the bottom of the brain called the amygdala, which is all our neural structures are interconnected for the most part, and so we, by necessity, oversimplify and categorize them as limbic or cortical or occipital or cerebellar, peripheral, brainstem, and so forth and so on. But we understand they're all connected. And with a brain on fire caused by the inflammatory process that LBC brings about like no other disease, the lower brain, in my view, is more seriously affected than the upper brain, although the whole brain is infected. And part of the lower brain, that includes the hypothalamus, the thalamus itself, the amygdala, the hippocampus, our memory stores for short and long-term memory, the basal ganglia, and the other structures, mammary bodies, et cetera, et cetera. Well, the amygdala is the devil gland because it's our seat of fight or flight, fear, and so forth. And it has an appropriate role, but it takes over our prefrontal cortex, which modulates information coming to it, but it's just overwhelmed by the amygdala because it's got the upper hand. Well, not that it has the upper hand. It does, because the prefrontal cortex is compromised, but the amygdala is hot, like a hot coal, and it fires off these neurotransmitters, and the lower brain, you have to understand, does not think. Okay? It doesn't think. So we're recording this now. If somebody opened the door suddenly and said, oh, I'm sorry, I'm in the wrong, oh my gosh, oh my gosh. If Rachel's amygdala was red hot, she would jump out of the chair. And if it's one of my employees that did that, I'd turn around and say, you're fired. So the point is, I was able to process in a millisecond, what happened. I didn't have a startle reflex necessarily. I mean, not that I would never startle about anything. That's not the point. But the point is that inappropriate stimuli will create tremendous overreactivity. And if it's an ongoing thing, people can be miserable. I think just live in terror, panic, and so forth. And so this is one mechanism from that particular area, which I think is a dominant area, in the fact that we can't process it.
And a question that goes along with that, somebody wrote in asking if we've ever seen adverse reactions from the medication Lamictal or lamotrigine. Were anger, paranoia, and hallucinations.
Absolutely. So all our medications are capable of causing paradoxical reactions. Actually, that's another roadblock down the road. Because, and it can happen after medications patients absolutely require, and which absolutely benefit them. After a while, after the brain changes, drugs like Lamictal, but not so much Lamictal, but Lamictal can do it, become not their friends. So it's because they're starting to have paradoxical reactions. Well, in this case, this is not a paradoxical reaction. This is an intolerance based on the person's neurochemistry. Now, we use a handful of very select neurotropic agents. They're all seizure drugs, basically, but they're not super good seizure drugs, but they're seizure drugs. But they're very good at reducing ion flow. So nerves will fire once ions cross the nerve membrane and back and forth, and that's what excites the nerve. You get a propulsive type effect. So Lamictal controls, Lamictal, oxcarbazepine or trileptal, Tegretol, zonisamide, pretty much work with sodium and potassium channels, whereas gabapentin and Neurontin and pregabalin or Lyrica work with calcium channels. So and each has their propensity to do things that some of the others don't do. We like to use them together, quite honestly, at the lowest effective dose through synergy, which is something we've done for a long time to control pain and to control limbic irritability. But we tend to introduce things at very low dose. We don't tend, we do. And it's only after a period of time. where we've established all the necessary information about the patient. We'll introduce these meds to help stabilize the patient's limbic irritability or generalized central nervous system irritability. Sometimes this is not that common with lamotrigine, but it certainly can happen with any of the drugs that I just mentioned, as well as other drugs. And so it's that drug is not, that goes on the off list. That's off the table, sir, and we'll never use that again. Thank you.
And something that I wanted to just kind of follow up with in regards to Dr. Jemsek's response, something that we've seen with patients that have tried a lot of these neurotropic medications or stabilization medications, when they come to us and they've already tried meds that they're fearful of because of adverse reactions, something that we've started to do a little bit more frequently is genetic testing, looking into positive or possible mutations that they may have that link with adverse reactions to specifically those medications. And that helps us to be guided in regards to which medications we can use to help you. So just as a side note, Dr. Jemsek has a follow-up on that.
Yeah, we're doing pharmacologic testing on the P450 cytochrome, and just had some bad news the other day. This is just what drives me crazy about our healthcare system, which is run by the insurance companies, and the hospitals are their, friends in, mischief. So it's all about controlling the doctors. Make the doctor the puppet, and the doctors, for the most part, don't understand their puppets. I said I wouldn't be political. That's enough. Stop. Stop. Don't get me started. But unfortunately, we have a very excellent lab in Hamilton, New Jersey, Medical Diagnostics Lab, MDL. They have this marvelous worksheet for testing through swabs or saliva to test for pharmacologic properties based on cytochrome profiles in our patients, which tell us which drug in which group is best for that patient. And unfortunately, it used to be covered by insurance. So I learned last week now insurance won't cover it. And they'll apply to insurance. But, it's not like they don't have enough money. Stop it. I won't get political. But I'm sorry about that. So if we do a proper pharmacologic screen, which I think is important, particularly in our more complex patients and more advanced patients, it's going to be $400 or $500, and I'm sorry about that.
So the next question that someone sent in, it's asking, what can one do when they have Lyme and co-infections, but don't have the financial means to pay a Lyme literate physician? This is a great question, particularly because, as most of you know, Lyme disease is not a cheap disease. No matter kind of how you look at it, whether you're approaching it from an herbal treatment standpoint or an antibiotic treatment standpoint or other, because there are other categories. What we typically recommend for patients that are unable to afford a Lyme literate physician is trying to look at your lifestyle and find ways of compensating or reducing inflammation in a more natural way. On our website, we actually have outlined different lifestyle changes that can help. I think it's under self-help tools on our website. And this is talking about different detox modalities, whether it be Epsom salt baths or low inflammation diet, hydration, etc. Tolerable exercise, as well as some general over-the-counter supplements that for most of the general population can help to reduce inflammation. By incorporating some of these things, sometimes patients can achieve a modicum of stabilization while they're trying to grapple with this disease, even if they can't afford it. So we understand it's a really expensive disease. It's a pain. It frustrates us immensely, but there are some things that you can do just on your own before you even talk to a doctor. The third question that I want to get into, you have asked about treatment of Bartonella. So one of the questions as it pertains to Bartonella is if you're allergic to fluoroquinolones, which for the layperson would include Cipro and Levaquin, which are scary drugs or black box drugs for some patients. Is there a way around treating Bartonella? With the fluoroquinolones, one thing that we ask our patients is, do you have a true allergy to this? Many times patients will have symptoms pertaining to dosing Cipro, which might actually line up with Bartonella symptoms, tendinosis, tendinopathy, and not actually be true side effects to the medication. So figuring out whether there's a true allergy there, first and foremost, is important. The other component is that there are other medications that we use to treat or cover for Bartonella. Rifampin and rifabutin are two that are pretty powerful in covering for this co-infection of Bartonella. Ceftra is another one, and we use other broad-spectrum antibiotics at the same time, as you know. Another question that you guys have asked as it pertains to Bartonella, why we pulse treat Bartonella, and for that I'm going to pass it over to Dr. Jemsek.
Thank you, Rachel. As far as therapeutics go, she's exactly right. We see a lot of what's called enthesopathy, which is periarticular involvement. This disease seems to like tendons and ligaments as much as joints and synovial tissue itself. And so if somebody flares, the question is, with our very potent quinolone, which we don't use in the beginning, by the way, and we use judiciously, was this a Herx, or was this a true tendinopathy at risk? So if our patient has EDS or is in the EDS spectrum, Ehlers-Danlos syndrome spectrum, excuse me, if they're hypermobile, we tend to be a little more cautious, and they may tend to have a few more issues with the quinolones. We hate to give it up because the quinolones are the only other group other than penicillins and cephalosporins which are bactericidal, meaning that on contact they will kill the target organism so long as the target organism is in a certain phase of replication or phase of lifestyle. So we hate to give it up. And the options are rifamycins, rifabutin, and rifampin, and Ceftra. And of course, everyone knows that a number of us have issues with sulfa compounds. And so sometimes, so the literature's shows that here and there you'll see doxycycline helped or minocycline helped or zithromax helped. Now, so we're trying to do our best. We're constantly looking for options. And the good news is that in the quinolone group, I would say the incidence of adverse effects is on the order of 5 to 10%. The problem is the adverse effect can last for up to 3 to 4 months. But we're very cautious in giving it. Everyone knows about the tendinopathy that's, quote, black box, end quote. But again, these are very valuable. It's probably the most potent drug when given on an as recommended basis that we have. And we never give it early in a treatment. We never give rifampin early in a treatment. They can be too reactive. By the way, I think rifabutin is a much better drug as a congener or relative derived from rifampin. Much better drug, much cleaner drug. And we've been using that from the get-go for many years. My friend Yang Zhang at Hopkins, PhD, MD, microbiologist, putting all these test tube reports in publication. His group did a couple of reports on botanicals. One was, which botanical kills the persister form of Berliosis burgdorferi most efficiently, and which one kills the live type form most efficiently. And they also looked at Bartonella. I think they looked at Henselae alone, but they may have looked at Quintana as well. I'm not sure. But in both cases, Cryptolepis, your favorite drug, your favorite herb, was the best. So we love Cryptolepis, and we work with our patients to try to get them to take it, encapsulate it, take it with pomegranate, just whatever. But anyway, Cryptolepis is another tool, and so is methylene blue, which we can talk about another time.
More bad news about yucky tasting medication. So one of the other questions that we wanted to cover today, and this question we've gotten multiple times, but just to reiterate it, on the Jemsek protocol, how quickly can one with chronic Lyme disease expect to see some improvements? What is the average length of treatment to reach remission? At what point do most patients start to turn a corner at JSC? I tend to speak more generally, and Dr. Jemsek, I let him get into the nitty-gritty. So for the general response to that question, treatment typically at JSC is 12 to 15 months, and then we move into more of a maintenance phase of treatment. Some patients can go longer than that based on their amount of infection, their genetic predisposition, their support that's in place. Some patients can go for shorter periods of time. We know that our pediatric population typically doesn't need to treat for nearly as long as our adult population. There are a lot of different things that go into when patients start to feel better. And Dr. I would like to say that, we see improvements, when patients are able to go through our stabilization phase even before we treat many times, which is all aimed at reducing inflammation levels. And then Dr. Jemsek will talk a little bit more about immune reconstitution or immune system playing a role and when we start to see turnover in that regard.
Thank you, Rachel. Good points. So if you haven't been down this road, it's hard to go down this road. But when you've done it thousands of times, you have confidence in what the outcomes can be. When I was a younger man and learning infectious diseases, or maybe it was before that, just in medicine, some wise professor, and there were a few back then, I'm not so sure now, but I'm not mumbling, I'm just trying to not get in trouble, said to me, it's really important to know what the outcome of an untreated disease is versus a treated disease. For example, untreated disease may resolve in 10 days, but the patient may have a higher morbidity or mortality. The treated disease may not resolve for 9 days, but the mortality would be better. So you need to know what happens with treatment or without treatment and with certain treatment. And so since we have no reliable markers, and that's one thing the GLA study was going to help us with, so it's so unfortunate that COVID has wrecked another adventure. But we'll recover and we'll do this. But what's so important is to recognize patterns in medicine, and that's practice of medicine, recognizing patterns. And so when we talk about therapy, we start slowly and we talk about manageability. So we tell our patients, number one, you're going to get better if we believe they're going to get better, and we don't lie to our patients. You're going to get better. You got the support. I'm checking the boxes here. I think we're going to be good to go as soon as we get some data in. You do this, that, and the other. You have a good chance of getting better, whether you're oral patient or IV patient. You can get better. You can do this. We've done this. And but the patterns are very important. And one of my patients, Scott, wrote a very sweet note about us helping him and asked if there were markers. They're not, Scott. So patterns are extremely important. And so we know that you have to be patient. And initially so yes, most people know we'll treat for 3 days a week for a couple of weeks and then give a week off, and then eventually we move along a little further with Babesia treatment, and then things get a lot more intense, and then I don't pulse. When I'm really into more intense therapy, I don't pulse the second week when we're in a kill zone after we've broken down biofilm. But we start to see blue sky days. So people talk about blue sky days. Everybody identifies with that, and it starts with a blue sky morning or blue sky hour or blue sky afternoon. Then you link a couple of days together where you don't feel inflamed or besought upon. And with everything else equal, it's not like you can go do the marathon, by the way, but things are better. Maybe you have more clarity that day. Maybe you have less pain that day, a lot less pain, more energy. And then we build on that. And what that reflects is immunologic capital being acquired. We're trying to shift the paradox so that the immune system is no longer below deck, fanning flames, making fire, but not able to get on the top of the deck and wash the deck down. And so that takes a few months because we're dealing with multiple targets, we're dealing with biofilm, we're dealing with gut issues, we're dealing with all kinds of perturbation through the central and peripheral nervous system, not to mention other systems. And so 5 or 6 months, we do individualized therapy, but we do have a general platform and way of approaching things, and we'll change it if things aren't going well. Then after another few months of therapy, we start to get periods of a week or 10 days or up to 2 weeks of tranquility. And it's been my experience for many years that if we can get 2 cycles in a row with up to 2 weeks of tranquility, we're there. We're good. We can move on. And that's great. Because now you're going to be in a healing phase. You got your immune system. Now we're not going to stop therapy altogether. We're going to give you a few days a month. That's it. You're going to continue with your neurotropics. We'll wean those, and the psychotropics will wean those, and maybe cut back on your supplements. as we're able to, we'll make sure you're still sleeping, that the pain's under control, that your mood's okay, and that you're detoxing on a regular basis. It's become a lifestyle. So we have remarkable uniformity, not 100%, maybe 80%, 85%, maybe more, of being able to get this done in 12 to 13, maybe 14 months. Now, there are some outliers. Some of you say, well, I've been being treated for 4 years. Well, that's true. But you've had some good times, and you felt better at certain times, and we try to identify what set you aside. That's what these roadblocks are about. Thank you.
And that was a great way of explaining it. Going back to just, again, how I generalize things, you know, just listening to Dr. Jemsek describe that, I think many of you will kind of be able to tune into the fact that this is complex. The providers, as we go through this journey with you, we're constantly monitoring, you know, 25, 30, 50 plus variables that affect you on a regular basis. You know, and every patient is different. And so we'll have some patients that will have response very early in treatment, and other patients that it takes longer, and this could be because of other compounding factors. I always kind of describe it to the patients that I see more regularly as it's kind of a retrospective study type disease. You know, it's 2 steps forward, 1 step back. But many times if we look at your problem list from your very first visit, once we're a year or 2 into treatment, it's then that patients will realize how far they've actually come. So moving on to the next question, and this one Dr. Jemsek was excited to answer. What causes seizures with chronic Lyme when epilepsy has been ruled out?
Ruled out by who? The reason I didn't say excited, I'm not sure that's one. But it chagrined, bemused, annoyed. Okay, here's the deal. Remember I talked about the upper brain, the lower brain. The lower brain doesn't think. The limbic system with all its compartments, very important. The reptilian brain does not think, but it's packed. Everything goes through there, right? Everything from the somatic body goes through there on the way to the cortex. And that's where the white matter is, okay? Lower brain, white matter, upper brain, gray matter, right? So when you have little spots on the MR, those are demyelinating lesions. They're not small strokes unless you're 85. I'm not going to go with that. If you're, 23 and you have white lesions on your brain on the MR, which I'm sorry if some of you, I'm not sure what I'm talking about, so I'll stop talking about it. But the point is that the white matter gets hammered. And it's like, it's like taking the filtering system, the engine, if you will, everything that's manifest and transmitted to the wheels and to the driver and everything else who makes decisions. It's like taking that and ripping that up and sending it sideways, several times sideways. So when that happens, that's brain tissue, right? So you can have seizures in brain tissue. Now, that's not the same as Jacksonian classic seizures. They're not. Here's the rub. So if I've heard this once, I've heard it, I'm guessing, I don't know how many times. I hate to exaggerate, but I'm maybe 700, 800 times. That's not an exaggeration because, over the years. Patient A goes to local hospital, is having involuntary movement, contractions, and jerking their head back. Generally, there's no incontinence, there's no tongue biting, but there certainly are heavy contractions, and it's not a pleasant experience. And the neurologist will say, okay, we'll do an EEG. So EEG is normal. This has happened hundreds of times. Yeah, you got a little spike, but it doesn't explain that. I think these are pseudo-seizures, which technically is okay, but realistically and real world, it's insulting because it means you're faking it. And that nothing makes me or my patients more agitated than to hear that, oh, you're faking these seizures. Yeah, I want to be in convulsions, 4 times a day, 5 days a week. That's what I want to do. Or I want to be in the hospital 2 straight days in constant convulsions. Well, your EEG's normal. Here's the rub. Our EEGs only measure the cortex. They only measure the gray matter. They only measure the gray matter. they miss where the activity is in the limbic system, in the subcortical system. That's where all the firing off. That's electrical tissue too, big time. It's firing off. It's unhappy. It's going every which way, and it's causing these motor contractions. And interestingly, our patients can often know or hear what's going on, but they can't speak, and they're not postictal. So there are clear differences here. I would say that, I would go so far to say, as you know, I'm known for bold statements, but after you see a few thousand patients, I think you're entitled. I would say that the seizures are called subcortical seizures or paroxysmal limbic discharge, or whatever name you want to give to it. I would say these seizures are the most common seizures on the planet. The most common seizures on the planet. And our neurologists miss it 98% of the time because they got their little toy with the EEG and it doesn't show anything. It's maddening. So, you know, we'll do what we can to stabilize the patient with a combination of CBDs or benzodiazepines and the neurotropics and clean lifestyle to start with, of course. And we're generally highly successful, but some are tougher than others. So seizures are not mystifying to us. Hopefully we demystified it. And hopefully you haven't been victimized by community ignorance. And I'm happy to educate anybody about it, but nobody seems to want to listen. But this is very common. It's limbic irritability. It's not measured by EEG. So thank you for the question, but this is the answer.
I think following on that, you know, finding a neurologist, and they do exist, but neurologists that, you know, think outside the box and are willing to work with the patient and not just the test is key. Another question that we wanted to get to, a patient asked, they stated that they had been bedridden for 4 years, severe pain, fevers, neuropathy. Can people be too sick to start antibiotics? And this is, you know, unfortunately a type of question in a case that we see quite frequently. And it, you know, distresses us, you know, to the nth degree, because of course we want to help every single patient that we possibly can. But the fact of the matter is that there are patients that are too sick to even start antibiotics. And I'd refer you to start listening to the beginning of this, you know, Facebook Live when Dr. Jemsek talks about the poem's instability, because a lot of these components need to be stabilized before patients can tolerate antibiotics. If we put you on antibiotics when you're in that severe of pain or not sleeping, etc., quite frankly, you won't do well. You will not get better. And that's, you know, that's the fact of the matter. Two things that I wanted to cover that patients had written in about before we get to another question that you guys had written in about previously. A patient had written asking Dr. Jemsek how long we retreat Babesia if we're retreating once patients are in maintenance, where in maintenance we might treat, and which modalities of treatment or which medications we might use. Hopefully not too difficult of a question as this is addressed.
That's fine. We don't know yet. We're just starting to do this because we're about to get the next wave of patients coming through once we made a decision to retreat. So very soon we'll see those patients come through. I'm saying 2 to 3 months of full Babesia treatment, which means an overriding beta-lactam if possible, if it's tolerated, sulfa if it's tolerated, if not clindamycin, because these are support drugs for pure plasma infections as in malaria. Maybe doxycycline if it's tolerated. And then our something from the Artemisia group. Artemisinin is more potent. Artemisia is the mother compound. The potency of the Artemisia groups depends on the formation of dihydroartemisinin, which is the active molecule, and artemisinin will create a great deal more molecules of that type than Artemisia, but some folks can't tolerate artemisinin, so they go with Artemisia. Unfortunately, something from the atovaquone group. I think pure atovaquone, which is Mepron. I hear you out there. And this combination of atovaquone and I forgot Progranil, thank you, 100 milligrams. I don't think Progranil is even additive. It might be a negative thing. So I just don't think it's as good. But it can be effective, and then we can't get as much atovaquone. We have because it's only 250 milligrams. When we dose our Mepron, we're dosing 1,500 milligrams twice a day. So, and then we wanted to use Inula, which works a lot like the artemisinin group in terms of interrupting with the iron pathway mechanisms in Babesia. And then finally Cryptolepis, which I think synergizes nicely with artemisinin. And methylene blue, which I'm teasing you with, also much better Bartonella drug, much better malaria drug than it is Babesia drug. But when given with artemisinin group, it adds some benefit. So we'll do that, and then we'll do our biofilm, of course. And then week 2, we go straight through. So the antimalarial compounds will treat 5 days in a row. That's our kill zone. We kill, 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 and then we give our patients a break, let them detox, re-equilibrate, and so forth, and we do it again. So with our treated patients, with their immune system on board, it's going to be interesting to see how they respond. I think they'll do fine. I'm not sure whether you should do 2 or 3 cycles. I'll bet you most of them say, let's do 3, because they don't want to go through this again. Again, Babesia is the #1 cause of relapsing Lyme borreliosis complex. It is the driver for this illness, and it is a primary reason for relapse. And this is from all our clinical experience over many, many years, and paying a lot of attention and doing exams on a regular basis.
So yeah, so just to reiterate, 2 to 3 cycles in maintenance using a lot of the same medications we use with full Babesia treatment. But again, we are learning right along with you guys, and so until we get feedback with some of our patients, we won't know. 2 other things I wanted to touch on before we run out of time. You guys have sent in some really good questions while we've been live. One of the questions that you guys have asked is whether we can treat you online, whether it be because you're in the U.S. and too sick to travel, or whether you live internationally. And this is a really great question. Unfortunately, this is not a disease that can be treated, virtually. In the time of COVID crisis, we have attempted to adjust our expectations from the patient and so on and so forth. But when it comes down to it, like Dr. Jemsek said, we have to do a thorough exam. We have to be able to see, what your responses are, how you're able to keep up from a fatigue standpoint with answering questions during an interview, things like that. We take all of that into account. Also, from a liability standpoint, within the medical practice and medical insurance, we have to be able to do in-office visits just to keep our clinic safe. So while we would love to do online treatment or virtual treatment, it's just not feasible as a primary modality of therapy. We do offer patients to do phone consultations in between their office visits once they are established with JSC. And then one last question is that patients did ask about the flu shot as we're getting into this time of year. Our typical stance on the flu shot, and Dr. Jemsek, you poke me if you want to add in on this, but our typical stance on the flu shot is that, it's typically only effective about 30% of the time. Many times if it's utilized with, I don't know, now I'm going to get political. Sometimes we have concerns in regards to any live viruses that could play into or negatively affect a fragile immune system that we're trying to treat with Lyme patients. So typically we'll recommend against it. Of course, you're going to have outlying groups like the elderly, that it's better safe than sorry, etc., that would potentially be worth getting the flu vaccine. But as a general rule, we typically recommend against it. And Dr. Jemsek has been flinching, so I'm going to turn it to him just in case he wants to respond to that.
You're pretty political there. 30%. What's St. Tony Fauci going to say about that? But I'm not totally anti-influenza, but I'd like our patients to be 2 or 3 years out, and where I think they're immunologically competent. And by the way, we don't have good measures or ways to document that. It's not like I can do a blood test and say, oh, your immune system is all rosy right now. We don't know. We can't do that, unfortunately. That's another thing that GLA and JSC could do as a project together. I think that'd be very important.
So yeah, that takes us to the full hour. We really enjoy answering your questions and hearing feedback from our patients, and then also people that are not yet patients at the clinic. We'll probably do another Facebook Live next month with another provider with Dr. Jemsek. But yeah, keep those questions coming.
Thanks, guys. Bye.